Now we are live, Anmol.
Yeah, we are live. You can start.
A very warm welcome to all our viewers and our eminent speaker, Dr. Balaji Manohar sir. I'm Dr. Anu Vashish. I'm membership director and host with Dr. Abhishek Dubey. He's the executive director and my co-host. I would like to thank Dr. Anmol Bagaria, CEO and founder at Cynodent, for organizing such amazing webinars for all the students. Now, Cynodent is a unique platform, first time in India, a digital healthcare platform that provides and enhances a good relationship between patients and doctors, and it enables real-time appointment scheduling system. Our goal is to create easy access to healthcare services and communication ways or appointment scheduling system, not only between dentist and patient, but also for medical practitioners, diagnostic labs, for radiological services, pharmaceutical services. Cynodent brings together at economic prices and minimum waiting time. Cynodent is also working for social welfare and humanity to enhance the quality of life by providing healthcare needs, healthcare awareness, and free treatment. Now, I would like to invite our speaker, Dr. Balaji Manohar. He has done his BDS from A.B. Shetty Memorial Institute of Dental Sciences, Mangalore, MDS in Periodontology from A.B. Shetty Memorial Institute of Dental Science, Mangalore, member of the Faculty of Dental Surgery, Royal College of Physicians and Surgeons, Glasgow, Master of Hospital Administration in 2018 from Swami Vivekanand Subharti University. He has 21 years of teaching experience guiding postgraduate students in periodontics. He is actively involved in specialty of periodontology and has received great leader in the Indian Society of Periodontology. He is holding various editorial positions in many journals and had publication in peer-reviewed journals and has more than 56 publications and 2 chapters in textbook. Being the best clinical presentation at Kuala Lumpur in 2019, at Asian Pacific Society of Periodontology conference. I would like to invite Dr. Balaji Manohar sir to begin with his session. Over to you, sir.
Yeah, thank you. Am I audible?
Yes, sir.
Yeah, I will share my screen. Right, is it visible?
Yes, sir, it's visible.
Yes, sir.
Right. Thank you very much, Dr. Anu Vashisht, for the warm welcome and my introduction. I'm very thankful to Cynodent, the global healthcare for all small association which has been started very recently, and the founder and CEO, Dr. Anmol Bagaria, for having invited me to come and be with you and speak to you. Dr. Abhishek Dubey, the Executive Director, thank you very much. And
Thank
just before starting, I was interacting with the three of them, and the three of them are very enthusiastic and energetic about doing a lot of things, not just for themselves, but for the general public as well. Many humanitarian activities are being carried out by these young and energetic people. So first of all, congratulations to you all for thinking out of the box and trying to give back to the society the best you can. And just to place on record, if there is any way you think I could be of any help, whatever is in my capacity, I would be really happy to help you all. Thank you. So thank you once again for having invited me today. Uh, right. So those of you who must be wondering where I am at Bhubaneswar, which is on the eastern coast of the country, in the state of Orissa, the capital of Orissa. And Orissa, as you all know, recently is being coming up very fast on the Indian arena. Duti Chand, you all must be knowing, the Arjuna awardee, and India's best kept secret is the state of Odisha. Right, this is Kalinga Institute of Dental Sciences, where I am working. Incidentally, I happen to be the principal over here. I joined here since 2019 February, and the college is ranked in the NIRF this year at the 17th position. And the college is affiliated to the Kalinga Institute of Industrial Technology. And I'm proud to tell you that KIIT University is an institute of eminence, a tag which has been given by the Ministry of Human Resource Development, Government of India, one of the 8 private institutions in the country to get this tag, 8 in the private and 8 in the government sector. So it's a very, very huge thing for all of us. And these are the various rankings that the university has in various categories. It's accredited with A grade in the NAC, and the university is at present at 42 in the NIRF ranking. All these things which I just told you, the uh, point of being trying to be the best and trying to get the best is all because of the motivation of this one person, Professor Achyuta Samanta, who is the founder of our university, and he is the one who motivates us to get going and achieve the best in the best which is possible. And you would be surprised to know that KIIT University is not the only university. You can see him surrounded by so many children. We also have a institute which is Kalinga Institute of Social Sciences, where about 30,000 tribal children are studying, and they are studying here, they are staying here, they are given free education, free food, free stay. So it is a huge thing. It's also a university where the student right from KG to PG can study free completely. So it's a very huge thing. I would love you all to come over and visit this place to see the magnitude and the amount of effort which is being put in to serve the humanity. Well, coming to the subject as such, we all know treatment of periodontitis still begins with the education and motivation of a patient regarding the oral hygiene maintenance, followed by oral prophylaxis, and if required, the surgical periodontal therapy which is instituted for them. But when adequate periodontal treatment is not rendered or is not given, uh, when periodontitis is there, it results in tooth loss. Well, tooth loss, when you're telling only periodontitis, is not the reason why a tooth loss may take place or extraction may need to be done. Extraction may also may be done in various other circumstances, like suppose there is a root fracture, as you can see. Well, all these pictures are from the internet. I don't claim any thing for about these pictures. They don't belong to me. I've taken it from this internet. Uh, you can see the root fracture. Nothing much can be done. You have to pull out the teeth. Instrument fracture. You can see the instrument which is fractured in the molar tooth over there, leading to the extraction of tooth. Maybe there is internal or external resorption which cannot be treated very much. So then also you need to do the extraction. Crown fractures may be leading to extraction, failed endodontic treatment, or the periodontal lesion which may not be able to be treated. Again, the result is extraction. And most often than not, large carious lesions in the crown may also be the only answer for this is extraction. So following tooth extraction, there is a dimensional change which takes place. The alveolar ridge, residual alveolar ridge change is inevitable. At the time of the tooth extraction, the pre-existing pathologies like the periodontal disease or maybe the periapical pathology which might be present may hasten the process of bone resorption. Now, within the first 6 months of tooth extraction, it is seen that the alveolar ridge loss is greater than about 50%. So it's a huge loss of alveolar bone, which results in the loss of alveolar ridge, which makes it difficult for any kind of restorative therapy to be performed. So to maintain the volume of bone at the optimal functional and aesthetic uh, uh, for the optimal aesthetic and functional outcome, whenever extraction is there, ridge preservation becomes very essential. So placement of various graft materials into the freshly extracted sockets has been advocated by many in multiple studies, and they have termed it as what we call as ridge preservation technique. Now, when this ridge preservation technique is being done, if you see the literature, there is a lot of reports where the ridge preservation is being done by using various type of graft materials, may it be autograft, may it be allograft, alloplast, xenograft. All these types of grafts have been used for the ridge preservation. Now, out of the available options which we are seeing, the allograft, xenograft, and alloplast, they demonstrate only osteoconductive property, except for maybe the allograft, the demineralized freeze-dried bone allograft, which also shows some osteoinductive properties. But autograft is the only one which possesses all the three properties, that is your the osteoconductive property, osteoinductive property, and the osteoproliferation. Now, these three properties have been described by in various articles, the most common ones being the articles published in Perio 2000 in 1999, which says that for most favorable results, an ideal bone graft should have all the three properties, which I told you. International Dental Journal, which says autogenous bone exhibits all three properties, so it's considered to be the gold standard. And the Journal of Periodontology in 2000 says that autogenous graft has got fast healing, is resistant to infection, and has good compliance, patient compliance, and acceptability. However, though it is a gold standard or the benchmark for grafting procedures, it's got its own limitation. We all know for autograft to be procured, it has to be either from an intraoral source or extraoral source, but most commonly it's the intraoral source. The availability is very limited. Probably from the site where we are doing the treatment, or maybe from the other site in the oral cavity, you would want to procure these graft materials, but it becomes very difficult to procure. You have another site where the graft has to be procured, so the patient complains of pain, and there is also resorption of bone graft, which is seen that the autogenous graft resorption is there. So when we know that this autograft is the benchmark or the gold standard, is there any other graft material of autogenous source which can be used alternatively instead of this autogenous bone graft? Now, if you see, the tooth and bone share many similarities. The teeth, cartilage, nerves, and the maxillofacial bones are embryologically derived from the neural crest cells. So they are all sharing the same origin. The enamel consists of about 96% of inorganic substance and 4% of organic substance. The dentine contains about 65% inorganic substance and about 35% organic substance. The cementum is roughly made up of 45 to 50% of the inorganic substance, and the rest 50 to 55% is made up of organic substance. But if you look closely, the alveolar bone which is there, it is very, very, very similar to the dentine which is there. because alveolar bone also has about 65% inorganic substance and about 35% of organic substance and water. Now, if you see, the tooth is a composite structure which consists of inorganic components, including the calcium phosphate lineage, and the organic component, basically, which is the collagen. Now, the tooth minerals which are present, these five biological calcium phosphates, that is your hydroxyapatite, octacalcium phosphate, tricalcium phosphate, the amorphous calcium phosphate, and the dicalcium phosphate dehydrate. Now, all these five minerals, when they interact reciprocally, these calcium phosphates are capable of remodeling the existing bone when it is grafted. So generally, when the extracted teeth have been discarded as infective medical waste around the world, wherever we see the tooth which is extracted is just thrown into the dustbin. So researchers focused on the bone inductive absorbable properties of the tooth and introduced the medical recycle of human tooth as a novel graft material. Now, as I mentioned here, Akazawa et al. In 2007, they came up with this concept of using the human tooth as an autogenous re, uh, source of graft material. Now, there are a lot of articles which are present. If you see the article published in the Journal of Advanced Prosthodontics, which says about the ridge preservation. Now, this was a case series which was done, and it was evaluated to evaluate clinically the efficiency or clinical efficiency of the autogenous tooth graft material, which was put as a graft material into the extraction socket. Now, within the limitation of this study, what they found was that the autogenous tooth graft material can be a favorable bone substitute in the extraction socket for the implant to be placed at that site at a later period of time. Similarly, another article which appeared in the Journal of Case Reports and Studies, they set to determine the possibility of radiographically evaluating the degree of marginal bone loss in humans after the guided bone regeneration was performed using the tooth-based graft material. Now, here also what they found in conclusion was it was a viable material for being used as a guided bone regeneration material, and which yielded stable marginal bone loss even after functional loading of implant was performed. So if I'll just quote another couple of studies before I go into the real picture where we are heading to. Another clinical study which appeared in the Implant Dentistry Journal in 2011 to evaluate whether the tooth graft material can be used for sinus augmentation. Here they tried to augment the sinus of 51 patients where 100 implants were going to be placed with sinus augmentation. And when they did the augmentation of sinus, they used the autogenous tooth bone graft material. And the results indicated that the autogenous tooth bone graft materials are an appropriate material which can be used for sinus augmentation. And another article which appeared in Advances in Dentistry and Oral Health, which was basically to see if the extracted tooth can be used as a bone graft material. And basically they used the dentin scaffold here to be used as a graft material. And as the other studies also showed, they also concluded that the bone regeneration which was seen after using the tooth substitute as a graft material yielded good results. Now, I would like to take you to a couple of studies which has been conducted by our Indian counterparts only. One such study which appeared in the Journal of Indian Society of Periodontology in 2016, where alveolar ridge preservation using autogenous tooth graft versus beta tricalcium phosphate alloplast was used. Now, this was a randomized control prospective clinical pilot study. I'll just tell you the briefly what exactly was done over here. You can see here, they enrolled about 15 subjects who had to undergo extraction and who also had agreed to undergo implant placement at a later period of time. Now, if you see the first picture, you can see that the lateral incisor, the canine, and the mandibular anterior teeth have to be extracted. So these tooth were extracted atraumatically. You can see after the extractions have been performed over here. And then one site was given or be grafted with beta tricalcium phosphate was used to graft that area, and the lower anterior region was left ungrafted, and the other canine region was grafted with the tooth graft material which was made from the patient's own teeth. Now, all these, after placing the graft material, chorionic membrane has been placed over the graft material so that the graft doesn't dislodge from position before the suturing has been placed over here. Now, if you see the picture which has appeared in the journal 7 days and 3 months post-operatively, the pictures on the top are the 7-day post-operative pictures. You can see there is wound healing going on. Suture has been removed here. This is the ungrafted site. You can still see some amount of bleeding over here. But after 3 months, you can see here the area where the beta tricalcium phosphate has been placed. You can see some amount of defect, or I will not say defect, some amount of deficiency which is present over here, and this is the area where the tooth graft was placed. And definitely in the mandibular anterior region, you can see the width of the ridge which was present at the 7-day position, whereas at the end of 3 months, you can definitely see the amount of ridge width which has been lost over a period of time because there is no grafting which has been done or the area was left ungrafted. Now, this is the ridge dimensions which was checked by the authors at the time of grafting as well as 3 months after the uh, treatment was done. You can see here, this is the socket where the beta tricalcium phosphate had been placed, and you can see the tooth bone graft which has been placed, and this is the ungrafted site which is present over here. Now you can see 3 months post-operatively, the resorption can be seen in the beta tricalcium phosphate site over here. This is the tooth graft site, and you can see there is immense loss of alveolar bone which has taken place. The height you can evaluate, which was present. You can see here, this was the height which has gone down because there is no grafting, and clinically you have already seen that the width was also lost. Over here you can see the height also which has been lost in this region. You can see here, right? So the dimensional changes of the ridges also was taken, the mean height and mean width which I was just describing to you all. You can see here, naturally the site which was left ungrafted, you can see the maximum dimensional change which has taken place when you compare it with the beta tricalcium phosphate, and then when you compare it to the autogenous tooth bone graft material, whether it be the height or maybe it the width of the alveolar bone, there is a marked difference between the three treatment protocols which have been formed, with the least dimensional changes which has been observed with the autogenous tooth bone graft material. Right, if you see the histologic picture, as I told you earlier, some of the patients had agreed to undergo the placement of implant after the socket had healed. So when the trephines were used to do the osteotomy for placing the implant, the bone material which came out from the osteotomy site were sent for histological evaluation, and you can see picture A is where the uh, autogenous tooth graft was used, and B is where beta tricalcium phosphate was used. And you can see here clearly there is new bone formation. New bone formation is seen, and you can see the osteoid formation, and you can see some inflammatory connective tissue as well. This is the osteoid, but when you compare it with the beta tricalcium phosphate, you can see there is very limited amount of new bone formation which is taking place, with lot of inflammatory connective tissue which is present over there. So it definitely showed that the autogenous tooth bone graft material had a better uh, propensity when the bone graft or can be used as a bone graft material. Now the same gentleman, Chaitanya, he also published another article in the Contemporary Clinical Dentistry Journal, where if you saw the earlier case, it was the patient's own tooth was used to or to be used as a graft material. But here, this article is going a step further, where the allogenous graft material, which has been prepared from the tooth, which has been taken. So, of course, the donors of the tooth were tested for the diseases like HIV, HBV, HCV, and other venereal diseases, which had to be negative before the tooth from these patients can be used as a graft material in other people. So after the results were negative, the tooth were sent to the Tata Memorial Institute or tissue bank, where the graft material was prepared using the tooth of other individual. And when these graft material was being introduced to the patients who had to get the uh, grafting done, they were informed about all these things. So if you read the article, it gives you all clear detail as to what was the protocol which was used over here. But my idea basically here is to tell you about the use of the tooth bone graft, which can be used as a graft material. So here what they did was they used they basically they they included patients who had at least 4 extractions to be done. You can see here 4 extractions have been performed automatically in the patient, and you can see the 4 sides which have been grafted. The whole tooth graft has been placed here. Only the dentine which was used as an allograft has been placed here. One side where there was no graft placed, and then the freeze dried bone allograft which has been placed over here in this place. Now all the areas where grafting has been done, again chorionic membrane has been placed so that the dissipation of graft material doesn't take place. This is a 7-day follow-up of the patient, one of the patients, which they have shown in the thing where the sutures have been removed. The 4 areas where grafting has or the treatment protocol has been done is showing healing. And this is a 7-day post-operative versus a 4-month post-operative clinical picture, where you can see the area where the whole tooth was used as graft material. The dimension is almost the same. The dentin was used as a graft material. You can see the width of the ridge which has been maintained over here. The ungrafted side, you can see there is some amount of ridge loss which has taken place in the ridge in the ungrafted area, and this is the freeze dried bone allograft which has been used over here. Now the CBCT which they have published over here, if you see the baseline and the 4-month later CBCT picture, if you see, if you draw a reference line, the red line being the reference line for you, and you can see the 4 sites where the grafting has been performed. And if you see the area where the freeze dried bone allograft and ungrafted area is present, you can see a marked reduction in height which has taken place after 4 months of time. But where the areas where dentin was used as a graft and the whole tooth was used as graft, there is not much of difference. Of course, there is some amount of resorption which has taken place, but comparatively with the baseline data, if you see and compare it with the ungrafted and the graft where FDBA was used, there is a significant difference between the two. Now, in these 2 articles itself, they have further mentioned that randomized clinical trials are needed to establish if the tooth graft has the regenerative potential in periodontal defects. Now, what we have seen till now is these graft materials being used in residual, or rather the extraction sockets where they have been used as graft. They are not used anywhere where the graft material or the autogenous tooth graft material can be used for regenerating periodontal defects. So this led us to think about it and to try out possibility of using the tooth graft as a periodontal regenerating material. So we wanted to evaluate the effectiveness of the autogenous tooth graft material in treatment of periodontal intrabony defects. So for this study, we had certain objectives in our mind, which was to evaluate the clinical attachment level when we use the autogenous tooth graft in the periodontal intrabony defect, and to also radiographically evaluate the crestal bone when these graft materials are used. So definitely, when we have trying out a study, we have to have certain inclusion criteria and exclusion criteria. So we included subjects who were between the age of 25 to 45 years age and were systemically healthy, who had certain intraosseous defects where grafting was required with a probing depth of about 5 to 8 millimeters. Grade 2 furcations were included, and also it was very important for us to select patients or include patients where some teeth or a few teeth might have to be extracted, maybe because of the periodontal problem, or maybe if it was an impacted tooth which can be used as a graft material when the periodontal defect was going to be grafted. We excluded subjects who were pregnant or who were lactating, who had substance abuse. Tooth which had prosthetic or endodontic treatment were excluded, and subjects who had undergone periodontal therapy in the last 6 months were excluded, or who were on antibiotics which are required for the systemic conditions were also excluded from the study. So 10 sites were selected for the study which had infrabony vertical defects, and the patients who were suffering from uh, generalized chronic periodontitis. We all know no therapy, no surgical therapy can be done. Surgical periodontal therapy can be done without the phase 1 therapy. So the subjects underwent their oral prophylaxis and then were reevaluated 3 to 4 weeks later. And once we felt that the oral hygiene maintenance of the patient was adequate, then only the subjects were taken up into the study. And the baseline parameters were recorded, which included the plaque index, gingival index, the pocket depth, the attachment level, and of course, we also conducted the radiographic examination, the IOPA, and the CBCT also was taken. If you see over here the defect study on the CBCT, you can see there is a vertical defect which can be seen between 1.4 and 1.5. You can see the defect clearly over here. That's the defect for you to see. This just one of the case pictures I am showing to you over here. And this is the clinical picture to show you the mandibular anterior teeth which were grade 2 mobile, which were used as the graft or the donor tooth for the graft preparation. So you can see after the atraumatic extraction, the tooth, the root cleaning has been done to remove all the residues. The excess endotoxins on from the root surface have been removed so that it can be used as a graft material. Now, we followed the same protocol which had been published in the article, the two articles which I showed you recently by Chaitanya Joshi. The two, as per the article where the graft was prepared using a domestic grinder, we also did the same and used the domestic grinder which we use usually in the kitchen to make or to grind the teeth. Now this is a 1500 watts, sorry, 700 watt, 1500 RPM conventional mixer grinder and the grinding jar which you see over there. The tooth was put into the jar and the grinding was done. The only thing which we did over here was for every patient we changed the jar so that there is no chance of any disease transmission. The jar just costs about 300 350 rupees, so it's okay to change the jar for every patient rather than use the same jar where we are not very sure whether there is any residues of the previous tooth which has been remaining over there. So we change the jar for each and every patient as and when required. So there you can see after the graft was the tooth was ground in the mixer, you can see the particles. It's a very close-up picture, and then the sieves to differentiate between the particle size. These sieves also we got it made custom made. You can see these sieves which are having the size ranging from 300 micron, 600 micron, 850 micron, and 1000 micron. So we use this sieve to separate out or differentiate out the size of particle by just using the sieve. And after this was done, we used the lactic acid to sterilize the graft material. Now this lactic acid is an organic acid. You might wonder why we use an organic acid when there are stronger acids like nitric acid or hydrochloric acid which are available. But nitric acid and hydrochloric acid, if you see, they are the inorganic acids, and these graft materials are going to come in contact with the bone and the tooth surface. So we did not want any untoward thing to happen. So that's why we use the lactic acid to sterilize the graft particles. Of course, when this sterilization is going on, there is some amount of what we call the decalcification also will take place. So the sterilization process was for about 20 minutes. We use the lactic acid, and after the 20 minutes, the particles, graft particles, were thoroughly cleaned with saline, with a copious amount of saline, which was used to clean the graft material of any uh, uh, acid or residual acid which may be present on the particles. Right. So after that, you can see here the reflection of the flap over there. You can see the immediately after reflection, you can see the defect which is present. This is just after the degranulation has been completed, and you can see the graft material being introduced into the defect area in the in between 1,4 and 1,5. Right after that, sutures were placed, and you can see you can very well imagine post-operative care was given to the patient. Patient was asked to rinse with 0.2% fluorexidine gluconate twice a day for 2 weeks, 14 days, and systemic antibiotics and analgesics were also prescribed to the patient for uh, preventing infection and for the pain relief. This is the 1 week post-operative picture when when the sutures have been removed. All subjects were recalled after 7 days for the suture removal, and they were evaluated for their oral hygiene maintenance at regular intervals. And all the clinical and radiographic parameters were recorded 6 months post-operatively. Now this is a CBCT which will show you the evaluation. You can see here we have evaluated the bone distance, or rather the regeneration of bone, if you want to see. This is the pre-operative CBCT where you can see the distance from the crest of the alveolar bone on the tooth here to the CEJ, and from the CEJ of one tooth to the crest of the alveolar bone on the adjacent tooth. So you can see here 5.5 and 9.5. So you can see here it has reduced to 3.9 and 6.2 over a period of time. Width also you can see 5.2, which was preoperatively, has reduced to 3.5. And then later the statistical evaluation was conducted for the study which was done. Well, I would not be in a position to explain the analysis, statistical analysis. I'm not a statistician to go into details of what type of test and how it was done. But I will definitely show you the results. If you see the plaque index, Turisty Gilmore Glickman plaque index, which was taken the baseline shows 0.92 as the plaque index, but at the end of 6 months, you can see it has reduced to 0.57, which was a significant reduction in the plaque. Gingival index also, the reduction was seen to be highly significant from 0.9 to 0.47. The probing depth, the mean probing depth at baseline was seen to be 7 millimeters, which reduced to 3.2 6 months after the treatment protocol had been done, which was again seen to be highly significant. Clinical attachment loss also was seen to be highly significant, which reduced to 3.2, which was at baseline seen to be 6.5 millimeter. The defect analysis, when it was done, at the baseline, it was seen that the defect volume which was measured was about 106, and which reduced to just 40.6, which was seen to be a very highly significant difference. Now, the use of the autogenous tooth bone graft material resulted in significant reduction of probing pocket depth and gain in clinical attachment level. Now, the particle size of the graft material influences the bone formation. If you go through the literature and the article published by Kogati, where they concluded that the larger particle size of partially demineralized graft induced prominent bone regeneration. Larger the particle size, slower is the resorption of that particle size. And if the particle size is too small, they resorb even before they are able to function as a graft material. Now, the retention of the blood clot is impaired when the interparticle distance is too large. That is, between the two bone graft particle, if the distance is too large, there is a problem of retention of the blood clot. Whereas if the distance between the two graft materials is too less, the blood vessels cannot readily enter the material when the distance is too small. So therefore, a particle size of somewhere between 300 to 850 micron has been suggested by the author to be chosen for the study. So I mean, sorry, 500 micron is the ideal size for the particle, and you can see in our study it ranged between 300 microns to 850 microns. We had the sieves for 300, 600, 850, and 1000 microns. Uh, if you draw conclusions from this study, what we could see basically was that there was reduction in the pocket depth over a period of 6 months when the autogenous tooth graft was used as a graft material in the periodontal defects. And there was gain in clinical attachment after the surgical procedure was done. And radiographically, the defect fill was appreciated over a period of 6 months, which was after the surgery. Now, this study or this thing which I have described to you has been published already in the Kathmandu University of Medical Journal, which is a PubMed and Scopus Index journal. And this study was basically carried out by one of my postgraduate, Dr. Vivek Devani, and this has appeared in the January issue of 2020. Now, further long-term studies need to be carried out to evaluate and compare the efficacy of the autogenous tooth graft in periodontal regeneration. Now, in a country like India, or maybe not just India, if you see a subcontinent of India, countries, third world countries like India, take it Pakistan, Nepal, Bangladesh, Sri Lanka, the periodontal problem of all the patients in this subcontinent is more or less the same. We all are genetically, the makeup is the same, and uh, the socioeconomic status also, probably maybe in India we might be a little better, but all throughout the subcontinent the socioeconomic status is also, I would say, poor. Education is poor, where we are not able to, you know, lay more emphasis on or give them more education on the maintenance of oral hygiene, and they do not understand the importance of that. And even though some people may be able to understand the importance of oral hygiene and the maintenance of oral hygiene, but when it comes to periodontal treatment, and when we say to the patient that there is grafting required and the bone grafting would cost you, let's say 10,000 rupees, it's going to cost you. The patient, even though he is wanting to get the treatment done, is not in a position to get the treatment done, because we all know, middle class family, if the salary of the person is just say about 25-30,000 rupees, and he is going to spend about a third of his salary on just treatment of periodontitis, definitely he will think, what does he, or what is he going to do for the rest of the month to provide for his family. So this is a very novel idea, or a novel technique, where the patient's own tooth could be used as a graft material to regenerate the lost periodontal, or rather the lost alveolar bone. So definitely, as I have mentioned here, long-term studies are required. This was just a 6-month study where we could see some amount of bone regeneration. Probably if these patients are going to be followed up for a longer period of time, we might come to know what exactly is the situation after a year, or after 2 years, or after 5 years, what is going to happen. So long-term studies are definitely the need of the hour when we are trying to give or make the patient gain back what he has lost. So with this, I would like to come to the end of my presentation, and this is the beautiful Sun Temple at Puri, which is just about 70 kilometers from here. I would be very happy if any one of you is coming over to Bhubaneswar to accompany you to this World Heritage Site and visit this Konark Temple. Thank you. Dr. Anmol, Dr. Abhishek.
Thank you so much, sir, for your valuable time and knowledge that you have imparted us with. There are a few questions that people would like to know from you, sir. What is the best graft according to you that can be used in cases?
I already mentioned in my presentation, the first 2-3 slides was on the type of graft material. That is the autograft is the gold standard to be used. It's the best thing because it is going to be procured from the same individual. But as I told you, it's got its own limitations. So alloplasts are available, commercially available. That is available in two forms: decalcified freeze-dried bone allograft and freeze-dried bone allograft, as well as the xenograft, which are sourced from the animal source. Allograft or xenograft can be used, or in combination as well, which will give you good results.
So we have another question, which is what are the various factors to be considered during the grafting procedure? The major factor to be considered.
Especially with what I did or generally?
So in general and specific both, you can say.
Okay. First and foremost thing is to understand what type of defect is present in the patient before you go into grafting. Whether the patient is having horizontal bone defect or it is a vertical bone defect. Horizontal bone defects, whenever they are present, it has been proved in literature that grafting in horizontal bone defects is not going to give you results. The first thing to understand is when there is vertical defect, it's a scaffold from where the blood is going to come from three sides or from two sides, where the regeneration would be possible. So that's the first factor to understand. Radiographically, what you see is very different from what you see clinically. Radiographically, you might see that because it's a two-dimensional picture, you would not be able to give. Of course, CBCT has come now, so it gives you a clearer picture. But taking CBCT is not possible in all the cases. It's not affordable also for everybody. So deciding to graft is usually after the flap is going to be opened. So making the things very clear to the patient beforehand, that look, when I am going to do the surgical procedure, if there is going to be a requirement of grafting procedure, graft may be used, has to be very clearly informed to the patient. This is one thing which you have to understand: vertical defect and the horizontal defect. Most common mistakes which are being done whenever the general dentist is practicing, and they ask the periodontist to come and do the surgery, is they tell the patient यहाँ पर graft लगाना पड़ेगा. They make the patient understand without realizing that what kind of defect is present. So that is the first thing the dentist has to understand, or each of us has to understand.
The
The
decision
type,
making of the graft.
yes, not the graft, the site. First,
Right.
you have to understand the site, what type of graft is required. I have seen myself, or rather experienced myself, the dentist has convinced the patient for graft, and I have gone and told, look, there is no grafting required over here. It's not required. So this is one major thing which you have to understand. And apart from that, the type of graft which you are going to use, of course, autograft is not an option, because you have to procure it from the patient. So to use an allograft or a xenograft is much more advisable than using an alloplast, which is just going to remain over there and form a scaffold over there. Rather, you have something which is going to induce or turn into bone, which is your allograft or xenograft.
Thank you so much, sir. Most of the questions which we had in the comment section are covered in your presentation. These two were the things we had in our comment section, so we had taken these two questions.
Thank you.
Thank you so much, sir, for giving your valuable time to us this evening and for delivering such an informative lecture. It's an honor and privilege to have you here, sir. Thank you so much, sir.
My pleasure.
Thank you so much, sir.
Thank you. Thank you for having invited me. I thoroughly enjoyed today morning when I was trying to make the presentation, and Dr. Anmol was, I think, a bit scared when I said I have not yet gone through the presentation. Well, anyways, all is well that ends well.
Yes, sir.
Perfect, sir. Perfect.
Thank you so much, sir.
Thank you. Thank you
Thank
very
you
much.
so much, sir.
Thank you. So can I log off or?
Yes, sir. I'm just ending this session.
Right. Thank you. Thank you very much.